Well, I would like to start by apologizing on Dr. Marush's behalf. As I said, he had an emergency come up, so he will not be able to join us. And I would like to say that I'm really honored to be presenting here in front of you all, especially on his behalf. So as you mentioned, the topic of our discussion today is atrial fibrillation burden and monitoring, current status, and future directions. So starting off with two AFib patients, as they come into the clinic, we can see on their charts that both of these patients have paroxysmal atrial fibrillation. Now, it would be normal for us to assume that both of these patients are going to have similar outcomes and similar natural history of their disease. However, this is a concept that I'm here to challenge today, because if we look deeper into these patients' rhythms, with green indicating sinus rhythm and red indicating atrial fibrillation, we can see that over a period of time, these patients have very different profiles of atrial fibrillation, what we've come to call atrial fibrillation burden. Atrial fibrillation burden is defined as the amount of time a patient has spent in atrial fibrillation over a certain monitoring period. There are many different ways to measure atrial fibrillation, one of which we have developed here at Triad is a smart device-based burden, which is based on a handheld EKG device which measures EKG once a day, and then through a certain algorithm that we have developed, we are able to quantify these patients' burden, something that we have termed SMERDN. Now, another way of measuring burden is non-invasive intermittent monitoring. This is done usually through Holter monitors or patches that are worn by the patient over a certain period of time and will allow us to quantify their burden over this period of time. Another way is invasive continuous monitoring. This is usually done with implantable cardiac devices, which continuously monitor the patients day and night and allow us to quantify their burden. Finally, with advancements in technology, we are now seeing wearable-based burden, usually through smartwatches that also quantify these patients' burden over a certain period of time. Now, as burden has gained popularity and traction over the years, a lot of studies have been done to associate it with a lot of outcomes in AFib. And what we have seen is that burden impacts major outcomes in AFib, mainly quality of life, new onset heart failure, thromboembolism, and mortality. Now, delving into the details of these associations, I'd like to start with some of our own data from the DCAF2 trial, where Dr. Njim was able to show that even in patients with recurrence after ablation, a decrease in SMERDN was associated with a decrease in symptom severity, and therefore an increase in quality of life. Furthermore, in this analysis, including around 40,000 patients by Steinberg et al., they showed that for every 10% increase in burden, we actually have an 8.9% increase in the risk of new onset heart failure. Now, while the association of heart failure and AFib is very well established at this point, what this shows us is that the details of atrial fibrillation and the burden of atrial fibrillation is actually important to these outcomes. And I'd like to move on and present two studies that show the association of burden and stroke risk, starting off with the TREND study that showed us that in patients with high burden, defined as an episode of more than 5.5 hours over the past 30 days, we actually have a more than 2 times increase in the risk of stroke when compared to low burden or no burden patients. This was further corroborated by the KP Rhythm study, in which the authors were able to identify a threshold of 11.4%, above which patients had a 3 times increase in their stroke risk, independent of risk factors such as the CHAS-VASc and Atrial scores. Now, another important accusation of burden, and this actually comes from the same group that gave us the data on heart failure. For every 10% burden increase, we actually have 6.1% increase in all-cause mortality. And this is very important because this shows us that an increase in burden is associated with very hard outcomes, and an increase with burden kills. Now, coming back to our more familiar data from the CASA-AF, here we see that patients with heart failure and atrial fibrillation, following their ablation, if we can decrease their burden to less than 50%, we can actually reduce their all-cause mortality by around 77%. Now, this shows us that we may need to redefine the way we look at ablation success and recurrence of atrial fibrillation after ablation. Now, not to get too bogged down into details, but if we delve deeper into burden, and what this study was doing is try to define patterns of burden or patterns of atrial fibrillation, and it did so through Hox parameters, which are simply aggregation, which is the clustering of the episodes, how close the episodes are together or how spread apart they are, as well as the number of rhythm transitions which means transitioning from sinus rhythm to AFib or AFib to sinus rhythm. Using these two parameters, the authors were able to describe a high and low risk group. The high risk group refers to patients with high aggregation, so high clustering of the episodes, as well as high number of rhythm transition, a high number of switching between AFib and sinus rhythm. And what they showed is that in this high-risk group, there was actually a significant increase in AFib recurrence after ablation. So now that we've shown how AFib burden is related to all of these outcomes and all of these parameters, it begs the question, do our current guidelines take this into consideration? Well, starting off with the guidelines, the European guidelines from the European Society of Cardiology, we can see that the only mention of population-based screening comes at a Class 2A Level B recommendation. And in terms of the United States guidelines coming from the American Heart Association as well as the USPSTF, they both determined that they cannot provide a consistent and sensitive screening strategy based on the evidence present for AFib. And this should not come as a shock because despite having a multitude of different screening strategies, all of these seem to fall short. Here we see an analysis coming from Denmark based on the Loop study, where they showed that our most sensitive strategy is an annual 30-day Holter monitor for 3 consecutive years. Now, as you may have noticed, even our best strategy comes at a sensitivity of around 55%, which is very lackluster. And this is not something that we can simply brush off because the ASSERT trial showed us that in patients over the age of 65, we actually see around 35% subclinical atrial tachyarrhythmias. Now, while these may be subclinical, they are not benign because they were associated with a significant increase in stroke risk at a hazard ratio of 2.5. So what about our patients with known AFib? How do we do when we try to quantify their burden? Well, unfortunately, once again, we fail, we fall short. This is because intermittent rhythm monitoring, as we had mentioned before, the Holters and the patches have many shortcomings. In this paper, comparing 2 patients with the same amount of burden, 20% here, we can see that our probability of accurately defining burden ranges from 1 to 28%. Now, this shows us 2 things. First is that intermittent rhythm monitoring is very dependent on the pattern of AFib present. Second, that even with a favorable pattern, we can see that our probability is only 28%, which again is very lackluster. So we seem to fail our patients at the screening and diagnosis phase, and as well after diagnosing them. So how do we fare after treating our patients? Well, current guidelines recommend a one-time 12-lead EKG at 12 months, followed by 3 7-day Holter monitors at 3, 6, and 12 months. However, as you can imagine, any AFib episodes falling between these monitoring periods is very easily missed, and therefore recurrences are very easily missed. And this was shown in this analysis from the Circa dose trial, where you can see that our current guideline followed strategy, which is present on the left side of your screen here, a 3-time 7-day Holter monitor actually misses 27% of AFib episodes over a year. And even if we were to double our monitoring time to 3 14-day Holter monitors, we would still miss 17% of AFib recurrences over a year. So we seem to fall short before diagnosing AFib, after diagnosing AFib, and after treating AFib. So how can we make AFib more accessible? As the scientific community has continued to ponder this question, many, including us at Triad, have looked towards wearables for the answers. This is because wearables have become more pervasive in the general population. And as you can see in this projection going all the way to 2034, wearables show no sign of slowing down. And not only this, but wearables could provide us with a patient-centered, non-invasive approach to screening and monitoring of patients. So at Triad, we've taken this and we've kind of ran with it, and I want to present you with 2 trials that we've done to try and look at this. The first is a 2-lane iPredict Prevent study. In this study, we will attempt to link burden and episode pattern with substrate progression and outcomes. We will be enrolling patients with atrial fibrillation, as well as patients at high risk of atrial fibrillation. We will take a baseline MRI, as well as a follow-up MRI after a year. These MRIs will help us to quantify the substrate in these patients. And in the year between the MRIs, we will be continuously monitoring the patients through a wearable device, a smartwatch, as well as intermittently monitoring the patient through patches. What this will allow us to do is once again link this burden and these patterns to not only the substrate progression, but also some certain predefined endpoints, such as cardiac remodeling, heart failure, hospitalizations, and mortality. And now moving on to the next study, and I'm actually really excited to talk about this because we have actually actively started recruiting and launched this study recently, is the heartbeat trial. With the heartbeat trial, we are planning to enroll 10,000 participants and gather more than 61 million hours of monitoring and integrate data from 3 different electronic health record platforms. The inclusion criteria for this study consists of any 2 of the diseases and conditions that you see on your screen right now. And the goal of this is to be able to vascular population to not only allow us to look at these diseases, but also to assess interactions, any possible interactions between these diseases. So once the patients are enrolled in this trial, they are provided with a Samsung watch that will perform daily continuous biometric monitoring, looking at many different biometric aspects and many different biometric variables. One of our main goals is to quantify lifetime burden. We want to give these patients the complete lifetime burden without having missed an episode, without having missed a beat, without having missed anything. And what this will allow us to do is to provide AFib classification with a much needed overhaul. Because as it stands today, AFib is classified in a very binary fashion. Yes, no, recurrence, no recurrence. However, we want to piece AFib together. We want to look at AFib burden, AFib density, which is again the clustering of AFib, whether they're all clustered together or more spread out. The pattern of AFib, whether this is defined as through Hox parameters, as we mentioned earlier, or through any other way, as well as CV disease interaction, as we had mentioned. Hopefully, by piecing all of these together through the heartbeat trial, we will be able to provide a comprehensive classification of atrial fibrillation. Now, I want to leave you guys with 2 take-home messages. The first being atrial fibrillation is not a binary disease. Burden is key to atrial fibrillation. Unfortunately, our current guidelines do not take this into account. Second, and my last point, is that wearables could provide a non-invasive, patient-centered approach to screen and monitor for AFib. Thank you.